Hello. Hello. Hello, everyone. Okay, I'll start the class. Connect quickly. Okay, I'll start the class. I'll be telling you about the diseases of the retina. See, eye is the only organ through which we can directly visualize the blood vessels. That is the retinal blood vessels. Okay, so that is why the eye acts like a window to diagnose most of the systemic vascular disorders like hypertension, diabetes, and other vascular disorders like collagen vascular disorders. So in some of the cases, we will be the ones who diagnose diabetes or hypertension for the first time in some of the patients. And the patients, they don't know that they have diabetes or hypertension. By looking at the fundus changes, we could diagnose diabetes or hypertension and some of the systemic vascular disorders. Then coming to the gross anatomy of the retina. So the retina is a transparent structure. So the color of the retina is due to the background color of retinal pigment epithelium and also from the choroid. Okay, so we can, when the neurosensory retina is detached from retinal pigment epithelium, that is in retinal detachment, we can see the grayish white retina. Okay, so grossly, the retina is divided into three zones. Okay, so the posterior area, and then the equator, and the anterior zone. Okay, so at the center of the retina, there is one area that is the macular area. Okay, so it is about 5.5 millimeters in diameter, and it is rich in cones. Then at the center of the macula, we have a foveal area, which is 1.5 millimeters in diameter, and it is 2 disc diameters temporal to the optic disc. Okay, so one disc diameter is equal to 1.5 millimeters. Okay, so 2 disc diameters means it's 3 millimeters temporal to the optic disc. Okay, so the optic disc is nothing but the intraocular portion of the optic nerve. Okay. So at the center of the fovea, we have a depressed area, so that is known as foveola. Okay, so it is 0.35 millimeters in diameter. Because it is a depressed area, so we get a bright light reflex from that area, and that is known as foveal reflex. Okay, so that foveal reflex is altered in case of macular pathologies like macular edema or any other macular pathologies. Okay, so and the visual acuity is most acute in the foveal area because there are only cones in that area. Okay, so at the center of the foveal area, there is an avascular zone. Okay, that is known as foveal avascular zone, which is 0.4 to 0.6 millimeters in diameter. Okay. So this is the gross anatomy of the retina. So this is the fundus picture. Okay. So the optic disc along with the retina is known as fundus. Okay. So we can see that there is optic disc. Okay. So that is the intraocular portion of the optic nerve is known as optic disc. Okay. That is known as optic nerve head. Okay. So it is pinkish in color, and at the center of the optic disc there is optic cup. Okay. And then from the optic disc, we're able to see that the central retinal artery and the central retinal vein, they emerge. Okay, so the central retinal, these vessels, they divide into, after emerging from the optic disc, they are divided into superior and the inferior branches. Okay, so the superior branch again divided into supranasal and the superiotemporal branches. The inferior, inferinasal and the inferotemporal branches. Okay, and we are able to see that they are divided in a dichotomous type. Okay, so when coming to when we see the caliber, see these are the arteries. The less caliber vessels are the arteries, and the more caliber vessels are the larger caliber vessels are the veins. Okay, so the normal A is to V ratio is 2 is to 3. Okay, and then when coming to the arteries, so the central retinal artery is a branch from the ophthalmic artery. Okay, so the arteries are the end arteries. There won't be any anastomosis between the arteries. They are the end arteries. Okay, and then at the disc we see the normally in 80 to 90% of the individuals we see the venous pulsations. Okay, but we don't see any arterial pulsations. If the arterial pulsations are seen, that means it is a abnormality. Okay, so there are some conditions where we can see the arterial pulsations, but normally we don't see the arterial pulsations. We see venous pulsations that in 80 to 90% of the individuals. Okay, and then I told that this is the posterior pole area where there is disc and the macular area. Okay, and then the other zone is the equatorial zone. This is marked by the vertex veins. Okay, are you able to see that there are flower-like veins? Okay, these are known as vertex veins, and the area surrounding those vertex veins is the equatorial region. Okay, and then anterior to the equatorial region, we have the anterior retinal zone. Okay, that is otherwise known as peripheral retina, which extends up to the oris areata. Okay, so it's very difficult to visualize normally the peripheral retina, but can be visualized only with the help of scleral indentation. Okay, that is with the help of indirect ophthalmoscopy. Okay. Then I told you that this is the macular area, 5.5 millimeters in diameter, and then the foveal area that is 1.5 millimeters in diameter, and at the center there is a foveal reflex. Okay, it is 0.35 millimeters in diameter. Okay. Then coming to the histological section of the retina, as you all know that there are 10 layers in the retina. So from outside to inside, it is the retinal pigment epithelium. Okay, and then the layer of photoreceptors, which consists of rods and cones. Okay, then the external limiting membrane, and then the outer nuclear layer, which consists of the nuclei of the photoreceptors. Okay, then the outer plexiform layer, which consists of the synapses between the photoreceptor layer and also the bipolar cells. Okay, and then the inner nuclear layer, which consists of the bipolar cells, and then the inner plexiform layer, which consists of synapses between the ganglion cell layer and the bipolar cell layer. Okay, and then the ganglion cell layer consists of ganglion cells, and the axons of the ganglion cells, they form the nerve fiber layer. Okay, so these nerve fibers, they unite and form the optic nerve. Okay, so this area is devoid of nerve fibers, and this is the optic cup. Okay. So out of these 10 layers, the outer 4 retinal layers are supplied by the choroidal vasculature. Okay, so that is choriocapillaries. Okay, whereas the inner 6 layers are supplied by the central retinal artery. Okay, and then there are altogether 120 million rods and 6.5 million cones. Okay, So the rods are helpful for peripheral vision and also for photopic vision, that is the visual acuity in dim light. Okay, whereas the cones are for photopic vision, that is the visual acuity in bright light and also for color vision. So that is about the gross anatomy and also the histology of the retina. Okay. Then come to how to examine this retina. Okay. The examination of the retina or the fundus is known as ophthalmoscopy. Okay. So what is ophthalmoscopy? So it is the examination of the eye behind the crystalline lens using special arrangement of lenses or mirrors so that the light which is reflected back from inside of the eye can be brought into the observer's eye to form an image. Okay. So there are different methods of examination of the retina. So that is with the help of direct ophthalmoscopy, indirect ophthalmoscopy, and also with the help of slit lamp, we can examine the retina by using special lenses like plus 60 diopters lens, plus 78D diopters, and then plus 90 diopters lens. And also there are different types of contact lenses, okay, for the examination of the retina. Contact lenses means we put the lens directly onto the cornea, okay. So there are like Goldman 3-mirror lens and also different types of laser lenses which are contact lenses, okay. So we put the lens on the cornea and then we visualize the retina and then we do the retinal lasers, okay. So direct ophthalmoscopy, indirect ophthalmoscopy, and then examination with slit lamp by using special type of lenses. Okay. Then coming to the, I'll just tell you briefly about the principle of direct ophthalmoscopy. Okay. So normally, if we if we look into the patient's eye, okay, directly, so we don't see anything, okay, we don't visualize anything because inside of the eye is dark, okay, so we don't visualize anything, okay. So if we try to illuminate an area of fundus with the light source from here, okay, so it illuminates this area, but when it is projected outside, it will be projected to this area only, okay, so it will not be projected into the observer side. So even by placing an illumination from side, we cannot visualize the fundus, okay. So in direct ophthalmoscopy, what they do is they incorporate a perforated mirror like this. Okay. So perforated mirror, through this, the reflected light rays they enter into the observer's eye and they produce an image. Okay. So like this, by placing a perforated mirror or by placing a prism or a plain mirror like this, we can visualize the patient's fundus. Okay. So that is the principle of direct ophthalmoscope. So by interposing a perforated mirror or a plain mirror or a prism, we can visualize the patient's retina. Okay. So that is the direct ophthalmoscope. So you can see here that this is the direct ophthalmoscope. Okay, very small instrument and also very easy to carry. Okay, and the technique itself is very easy. Okay, whereas this one is the indirect ophthalmoscope. Okay, so for doing indirect ophthalmoscopy, definitely we require experience. Okay. So it's not very easy to do indirect ophthalmoscopy. Okay. Then coming to the principle of indirect ophthalmoscopy. So in indirect ophthalmoscopy, we use a very strong, very high power convex lens. That is, usually we use plus 20 diopters lens. Okay. So by placing the high convex lens in front of the patient's eye, we make the patient's eye highly myopic. Okay. And then then there will be image formation between the lens and the observer. Okay, so we get an aerial image which is inverted, but it is real, okay, inverted and real image. Whereas in direct ophthalmoscope, we get an erect image, but it is virtual image, okay. So like this, so this is the convex lens, and then aerial image is formed between the lens and the observer, okay. Then, what are the advantages and disadvantages with each procedure? Okay, with direct and indirect. So, when coming to the magnification in direct ophthalmoscope, it is with the direct ophthalmoscope, it is 15 times magnification. Okay, whereas with indirect, it is when we use plus 20 diopters lens, it is 20 diopters magnification. It is 3 times magnification. Okay, so with direct, because it is 15 times magnification, so the field of view is very less. Okay, so it is only 10 degrees. The field of view is only 10 degrees, whereas with indirect it is 37 degrees. Okay, and then coming to the illumination, it is limited with direct ophthalmoscope, whereas with indirect ophthalmoscope, we get a high illumination, and so we can visualize even through the hazy media. Like even when there is a minimal amount of corneal opacity or lenticular opacity, that is an immature cataracts, and also even when there is a minimal vitreous hemorrhage or vitreous haze, even in those cases, we can visualize the fundus. Okay, and the stereopsis, that is the depth of focus. It is stereopsis is nothing but three-dimensional view. Okay, depth perception. Okay, so with direct ophthalmoscope, we get only the two-dimensional view. Okay, we don't get the depth perception. But with indirect, because we examine with both the eyes, so we get the depth perception. Okay, that is stereopsis. Okay. Then image orientation is, I told you now that it is virtual and direct image. So we need not again reverse the image for interpretation. Okay. So with the virtual and direct image, whereas with indirect it is we get real and inverted image. Okay. So the peripheral view is very limited, and we cannot see the peripheral retina with the help of direct ophthalmoscope. Whereas with indirect ophthalmoscope, we can visualize the entire peripheral retina even up to the oris aorta by doing what is known as scleral indentation or scleral depression. Okay, so that means if we are examining the eye with direct ophthalmoscope, that means we will be missing the peripheral retina, which constitutes about 30% of the whole retina. Okay, and the working distance is very close, and it is arm's length in with indirect ophthalmoscope. Okay, and then scleral indentation is difficult with direct, and it is easy with indirect. So those are the differences between direct and indirect ophthalmoscope. Then I told that even with the help of slit lamp, we can examine the fundus, that is by using either plus 60 diopters, plus 78 diopters, or plus 90 diopters lenses. Okay, so we place the lens in front of the patient and then patient's eye, and then we visualize the fundus. Okay, so the field of view is 30 to 40 degrees. Okay. Then coming to the vascular retinopathies. Okay, so the first one being the hypertensive retinopathy. Okay, okay, hypertensive retinopathy. So the retinal changes that occur in a patient with hypertension is known as hypertensive retinopathy. Okay, so then coming to the pathogenesis of hypertensive retinopathy. So the first one being the vasoconstriction. Okay, and the next one is the arteriosclerosis. Okay, and then increased vascular permeability, and then raised intracranial pressure. Okay, so the vasoconstriction, arteriosclerosis, and then increased vascular permeability and raised intracranial pressure. Okay, so the vasoconstriction. Okay, so it is the primary response to raised blood pressure. Okay, so it depends on the severity of hypertension. Okay, so the pure form of vasoconstriction occurs in young individuals. Okay, because in older individuals there will be already pre-existing involutional sclerosis. So when there is see, it's not only the choroid which is affected, it's not only the retina which is affected, even the choroid is also affected in hypertension. Okay, so yeah, because the choroid is present adjacent to the retina, even the choroidal changes can be seen in the fundus. Okay, so when there is vasospasm of the choroidal vessels, there will be choroidal and also retinal pigment epithelial ischemia. Okay, because the RP is very adjacent to the choroid and also it is supplied by the choriocapillaries. Okay, so whenever the choroidal vasculature is affected, even the RP is affected. Okay, so when there is vasospasm of the peripapillary choroid, okay, choroidal vasculature, then there will be optic disc ischemia, okay, leading to which is presented as hypertensive optic neuropathy. Okay, so yeah, that is about the vasospasm, okay, which is the first change that occurs when there is hypertension. Okay, so the next change is arteriosclerotic changes. Okay, so that means in arteriosclerotic changes, what happens is there will be proliferation in the vessel wall. Okay, so there will be proliferation and also hyaline decentration, and also there will be fibrosis within the vessel wall. Okay, and the vessel wall becomes thickened. Okay, so these changes are manifested as a change in the arteriolar reflex and also AV crossing changes, that is arteriovenous uh, crossing changes. Okay, so when the artery becomes thickened, okay, so at the AV crossing changes, at all the AV crossing changes, both the vein and the artery, they share a common adventitial sheath. Okay, so when the artery is thickened, what happens is this thickened artery compresses over the vein. Okay, and produces some changes which are known as AV crossing changes. Okay, so due to thickening of the vessel wall. Okay, so these changes they mainly depend upon the duration of hypertension. Okay, so the third change being the increased vascular permeability. Okay, so the first change being the vasospasm. Okay, and the next one is the arteriosclerotic changes. Okay, and the third one is the increased vascular permeability. Okay, so this results from hypoxia in severe hypertension. Okay, so what happens is there will be breakdown of inner blood retinal barrier. Okay, so there are two blood retinal barriers. Okay, so one is the inner blood retinal barrier, which is formed by the endothelium of the retinal capillaries. Okay, and then the other one is the outer blood retinal barrier, which is formed by the retinal pigment epithelium. Okay, so the inner blood retinal barrier by the endothelium of the retinal capillaries, outer blood retinal barrier by the retinal pigment epithelium. Okay, so in this increased vascular permeability, there will be breakdown of inner blood retinal barrier. Okay, so leading to the leakage of all the blood constituents. Okay, so that will lead to hemorrhages, retinal exudates, and then focal retinal edema, and also macular edema, and also disc edema. Okay, so that is the third change, that is increased vascular permeability. Okay, then the fourth one is the raised intracranial pressure. Okay, because of high blood pressure. Okay, so there will be increased intracranial pressure, which occurs in malignant or accelerated hypertension. Okay, leading to papilledema and optic disc ischemia. Okay, so papilla means it is the optic nerve head or optic disc. Okay, so optic disc or optic nerve head is known as papilla. Okay, when there is edema of that, it is known as papilledema. Okay. So the papilledema is the term which is given to the disc edema, which is secondary to raised intracranial pressure. Okay. So the pathogenesis, it constitutes vasoconstriction and then arteriosclerosis and increased vascular permeability and raised intracranial pressure. Then coming to the classification of hypertensive retinopathy. Okay, so the commonly used classification is Keith-Wasner and Barker classification. Okay, Keith-Wasner and Barker classification. Okay, so this classification, it relates the retinal vascular changes to survival of the patient. Okay, retinal vascular changes to survival of the patient. That means by looking at the retinal vascular changes, we can tell about the survival of the patient. Okay, so both of them are inversely proportional to each other. That means if more of the retinal vascular changes are present, then the survival rate is very less. Okay, so according to Keith-Wasner and Barker classification, there are 4 grades. Okay, so grade 1 is mild to moderate arteriolar narrowing. Okay, mild to moderate arteriolar narrowing. Okay, so when we see this picture, you can see that there are veins and the arteries. Okay, so I told you now that normal AV ratio is 2:3. Okay, but here it is altered. Almost the arteries are narrowed. Okay, we can say that it is like 1:3. Okay, so there is definitely arteriolar narrowing. Okay, so that is grade 1 hypertensive retinopathy. Okay, then grade 2 hypertensive retinopathy, we see moderate to marked arteriolar narrowing with exaggeration of light reflex. And then we see the AV crossing changes. Okay, arteriovenous crossing changes. Okay, so there are different AV crossing changes. Okay, so one is Salus sign. Okay, Salus sign, which is nothing but deflection of the vein. Okay, so when the sclerotic artery, it compresses over the vein, there is slight deflection of the vein. We're able to see that it is not following the normal course. Okay, so there is slight deflection of the vein. Okay, so this is known as Salus sign. Okay, so along with the arteriolar narrowing, there is AV crossing change. Okay, so this is. Then the other AV crossing changes are like bonnet sign. Okay, bonnet sign is banking of the vein distal to AV crossing changes. Okay, so distal to AV crossing. Okay, so here is a AV crossing. Okay, so we are able to see that there is banking of the vein distal to AV crossing. Okay, and this is known as bonnet sign. Okay, and the other sign is gun sign. Okay, so gun sign is nothing but tapering of the veins on either side of the AV crossing. Tapering of the vein. So how it appears is like there will be apparent discontinuity of the vein. Okay, so as if the vein is cut. Okay, on either side of the or behind the artery. Okay, so that is known as gun sign, which is nothing but tapering of the veins on either side of the AV crossing. Okay, so there are 3 signs. Okay, AV crossing changes. So Salus sign, which is deflection of the vein, and then bonnet sign, which is banking of the veins, and then gun sign, which is tapering of the veins. Okay, so that is about the grade 2 hypertensive retinopathy. Okay, then grade 3 hypertensive retinopathy. So retinal arteriolar narrowing. So there will be moderate to marked arteriolar narrowing, and then there will be prominent AV crossing changes. So along with these 2 features, okay, because already these 2 features are there in grade 2. Okay, so along with these 2 features, there will be retinal edema, cottonwool spots, flame-shaped hemorrhages. Okay, so this is due to the increased vascular permeability. Okay, So there will be, we can see that in this picture, there are cotton wool spots. So these are nothing but the cotton wool spots, and these are the superficial or flame-shaped retinal hemorrhages. Okay. So the flame-shaped or superficial hemorrhages are they're present in the nerve fiber layer. Okay. See the nerve fibers are very loosely arranged. Okay. So that is why we get a large hemorrhages, large superficial hemorrhages with irregular borders. Okay, so these are known as flame-shaped retinal hemorrhages. Okay, or superficial retinal hemorrhages. Okay, so these are the cotton wool spots. So normally they are grayish white in color. So these are otherwise known as soft exudates. Okay, soft exudates. Okay, so they are nothing but the nerve fiber layer infarcts. Okay, so they are nerve fiber layer infarcts. Okay, so they are present, definitely they are present in the nerve fiber layer. Okay, so they are just like cotton wools. Okay, they are fluffy with irregular borders. Okay. So these are the characteristic features of hypertensive retinopathy: superficial hemorrhages and the cotton wool spots. Okay, but hard exudates are usually the characteristic features. That hard exudates are they are situated in the deeper layers of the retina. Hard exudates are they're situated in the deeper layers of the retina, and also the dot and blot hemorrhages. They are otherwise known as deep retinal hemorrhages. Okay, see the deeper layers of the retina are very compactly arranged. Okay, so that is why the lesions in the deeper layers of the retina are they're well defined. Okay, and also they are small. Okay, when compared to the superficial lesions. Okay. So then coming to grade 4. So grade 4 is nothing but grade 3 plus papilledema. Okay. So I told you know that papilledema is nothing but the optic disc edema. Okay. So we are able to see the arteriolar narrowing, and then we are able to see the cotton wool spots and the superficial hemorrhages. Okay, so along with these findings, there is a disc edema. Then in this picture, how can we say that there is disc edema? Because the disc is having blurred margins. Okay, so the margins are not well defined. Okay, so there are blurred margins because of the edema of the nerve fiber layers, nerve fibers. Okay, so the margins are blurred, and when we see with the binocular instrument like indirect or with slit lamp examination, so we can see that the disc will be elevated. Disc will be elevated, edematous with blurred margins. Okay, so this is papilledema. Okay, disc edema. Okay, and then along with the disc edema, we are able to see that there are multiple small yellowish lesions. Okay, multiple small yellowish lesions. These are all hard exudates. Okay, and these hard exudates are arranged like a fan or star in macular area. Okay, so if it is a if it is an incomplete, okay, incomplete circle. So here there are no hard exudates. So it's an incomplete circle. Okay. So it is known as macular fan. Okay. So if it is a complete circle, even here, if the hard exudates are present, then it is a macular star. Okay. Here we are able to see some. So if it is a complete circle, then it is a macular star. Okay. So in papilledema, so along with the along with the grade 3 findings, there is the disc edema, and also there may be macular star or fan. Okay. So that is about the Keith-Wasner and Barker classification. Okay. So there are 4 grades. Okay. So grade 1, mild arteriolar narrowing, and then grade 2, then AV crossing changes, and then grade 3 along with the retinal changes like retinal hemorrhages and the cotton wool spots, and then grade 4 papilledema. Okay. And then the other classification is arteriosclerotic retinopathy by Schke's classification. Okay, so I told you know that in this is especially in case of elderly individuals, there will be arteriosclerotic changes. Okay, the classification there are four stages. Okay, so the arteriosclerotic changes are depicted as changes in the arteriolar reflex. Okay, so in stage one, there is widening of the arteriolar reflex. Okay, so, and then stage two, there is more diffuse and less bright reflex from the arterioles. Okay, then stage three, copper wire arteries, which are reddish brown arteriolar with reddish brown arteriolar reflex. Okay, stage four is silver wire arteries with opaque white arteriolar reflex. Okay, so this is arteriosclerotic retinopathy classification by Schke's. Okay, and then the other classification is modified Schke's classification. Okay, modified Schke's classification, which is a combination of Keith-Weisner-Barker classification and also the Schke's classification. Okay, so Keith-Weisner-Barker classification is nothing but the staging of retinopathy changes. Okay, so we have seen so all the retinopathy changes according to Keith-Weisner-Barker classification, and then the light reflex changes according to Schke's classification. So combination of Keith-Weisner and Schke's classification is the modified Schke's classification. Okay. So then coming to the third classification. Okay. So which is known as Mitchell-Wong classification. Mitchell-Wong classification. So this is the predictive of risk for cerebrovascular disease, coronary artery disease, and mortality. Okay. So Mitchell-Wong classification. So retinopathy description and then the systemic associations. Okay. And so it is divided into mild, moderate, and this is accelerated or malignant retinopathy. Okay. Mild, moderate, and then accelerated or malignant retinopathy. Okay. So in mild retinopathy, one or more of the following signs. Okay. So generalized arteriolar narrowing, focal arteriolar narrowing, AV crossing changes, and then arteriolar wall opacity like copper wiring or silver wiring. Okay, that is mild. Then coming to the systemic associations or the systemic risk. Okay, there is weak associations with the stroke, coronary heart disease, and cardiovascular mortality. Okay. Then moderate retinopathy is characterized by mild retinopathy with one or more of the following signs. Retinal hemorrhages may be dot and blot or flame-shaped hemorrhages, microaneurysms, cottonwool spots, and hard exudates. Okay, so if any one or more of the following features are present, then there is strong association with the stroke, congestive heart failure, renal dysfunction, and cardiovascular mortality. Okay, and then the third one is the accelerated or malignant retinopathy, characterized by moderate retinopathy signs plus optic disc swelling, papilledema. Okay, may be associated with the visual loss. Okay, so it is associated with the mortality and the renal failure. Okay, so this is Mitchell-Wong classification. Then coming to the hypertensive, this is the other classification, but the name of this classification is not given. So the hypertensive retinopathy can occur in four circumstances. Okay, can occur in four circumstances. Okay, so the hypertensive retinopathy changes mainly depends upon whether the vessels are young vessels or the old vessels. Okay, because the in the young vessels there won't be any sclerosis. Okay, whereas in older vessels definitely there will be some amount of sclerosis. Okay, so the first situation is known as simple hypertension without sclerosis. Okay, simple hypertension without sclerosis. So which occurs in young individuals. Okay, young and resilient vessels. Okay, so there will be generalized arteriolar narrowing or constriction. Okay, generalized arteriolar narrowing, and then the vessel becomes pale and unduly striped. Okay, there will be acute angle branching. Okay, so when it is persistent for some time, there may be flame-shaped hemorrhages and also cotton wool spots. Okay, so this is the simple hypertension without sclerosis, which occurs in young individuals. Okay, and the other one is the second one is hypertension with involutionary sclerosis. Okay, so that means it occurs in older individuals where there is already sclerosis. Okay, so then the picture will be similar to the arteriosclerotic retinopathy. Okay, arteriosclerotic retinopathy. We have seen, no, there will be changes in the light reflex from the arterioles. Okay, so there will be localized vascular constrictions or dilatations. Okay, so there will be vessel wall thickening. Okay, so we can see the hard exudates and hemorrhages, and also we can see the AV crossing changes, different AV crossing changes. So this is hypertension with involutionary sclerosis, okay, which occurs in older individuals. Okay. Then the third situation is the arteriolar sclerosis. Okay, arteriolar sclerosis. Okay, so for example, there is an young patient. Okay, so there is a high blood pressure for a prolonged time. Okay, so then what happens? So there will be diffuse hyperplasia of the vessel wall. Okay, and the young arteries, in the young arteries, there will be proliferative and fibrous changes. Okay, so these are commonly seen in kidney problems like chronic glomerulonephritis. Okay, and then it is known as albuminuric or renal retinopathy. Albuminuric or renal retinopathy. Okay, so the vessels become narrow or tortuous. Okay, narrow and tortuous. Okay, and there will be heavy crossing changes, and then hemorrhages, edema, and cotton wool spots. And we can see the macula, and then we can see the hard exudates which form as a macular star or fan. Okay, so this is the third situation, which is known as arteriolar sclerosis, which occurs in young individuals with prolonged high blood pressure. Okay, and the fourth one is the malignant hypertension. Okay, so as we have already seen that when there is an accelerated progression of hypertension in relatively young arteries, so when there is a high blood pressure which is fastly progressing, then these vessels are they are undefended by the sclerosis. Okay, so this is commonly seen in renal insufficiency. Okay, then we get what is known as hypertensive neuroretinopathy. Okay, neuro means it is the involvement of the optic disc. Okay, and then retina. Both the retina as well as the optic disc are involved. Okay, so this is known as hypertensive neuroretinopathy. Okay, so the retina is cloudy and edematous. So there will be a lot of edema. Okay, retinal edema, and the disc is also edematous. Okay. So we can see the cotton wool spots, hard exudates, and then macular star, and then vision is seriously affected in these patients, okay, because of the disc edema as well as the macular edema. The vision is seriously affected. Okay, so definitely it's a grave prognosis for life. Okay, so these are the four circumstances. So first one is the simple hypertension without sclerosis, and then hypertension with involutionary sclerosis, and then arteriolar sclerosis, and then malignant hypertension. Okay, so except hypertension with involutionary sclerosis, all the rest of the three conditions they occur in young vessels, okay, young individuals. Okay. And then coming to the acute hypertensive choroidopathy. Okay, I told you, no, it's not only the choroidal vasculature which is affected, but even it's not only the retinal vasculature which is affected, but even the choroidal vasculature is affected in hypertension. Okay, so when there is a severe hypertension, there will be choroidal ischemia. Okay, so along with the choroidal ischemia, there is the RPE, ischemic damage do occur. Okay, so they are manifested as acute focal retinal pigment epitheliopathy. Okay, acute focal retinal pigment epitheliopathy, which are presented as focal white spots in the fundus. Okay, focal white spots in the fundus. Okay, so the other feature is Elschnick spots. Okay, so in lens we also get what are known as Elschnick pearls. Okay, so the Elschnick pearls are seen in after cataract. Okay, but these are Elschnick spots. Okay, so we get small black spots which are surrounded by yellow halos. Okay, small black spots surrounded by yellow halos. They are the Elschnick spots. Okay, then Segrist streaks. Okay, Segrist streaks. These are linear configuration of the pigment along the choroidal arteries. Okay, linear configuration of pigment along the choroidal arterioles. Okay, and then the fourth lesion being the serous neurosensory retinal detachment. Okay, so the retinal detachment means when the neurosensory retina is separated from the retinal pigment epithelium. Okay, so that means from the retinal pigment epithelium, the rest of the 9 layers are detached. Okay, so that is known as because of the fluid collection underneath the retina. Okay, so that is known as serous neurosensory retinal detachment. Okay, so this is due to the breakdown of outer blood retinal barrier. Okay, so I told you know that the outer blood retinal barrier is the retinal pigment epithelium. Okay, so because of breakdown of outer blood retinal barrier, okay, there is serious neurosensory retinal detachment. So basically, this is due to ischemic damage to the retinal pigment epithelium, leading to exudative bullous RD. Okay, so these are the answer. So these are the hypertensive choroidopathy changes. Okay, so acute focal retinal pigment epitheliopathy, and then Elschnick spots, and then Segrist streaks, and then serous neurosensory retinal detachment. Okay, and then coming to the management of hypertensive retinopathy. So if it is a mild retinopathy, so we need to control the blood pressure. So if it is a moderate retinopathy, so apart from controlling the blood pressure, we need to assess the vascular risk factors like hypercholesterolemia. Okay, so if there is associated hypercholesterolemia, then we need to treat it. Okay, and then in malignant retinopathy, so mild, moderate, and then malignant retinopathy. So in malignant retinopathy, that is with malignant hypertension with papilledema, then it's a medical emergency. So there should be stepwise control of the blood pressure. Okay, so if we suddenly reduce the blood pressure, it may reduce the perfusion of the optic nerve head and also the central nervous system, leading to stroke. Okay, so that is why there should be a stepwise control of blood pressure in malignant hypertension. Okay, so I will just briefly tell you. Okay, so the different classifications, Keith-Wasner and Barker classification. So there are 4 grades, and then different AV crossing changes, and then arteriosclerotic retinopathy classification by Schiess. Okay, so there are 4 stages, and then modified Schiess classification, which is a combination of Keith-Wasner-Barker classification and also the Schiess classification. Okay, and then Mitchell-Wong classification. Okay, there are 3 grades like it is mild, moderate, and malignant retinopathy. And then the hypertensive retinopathy can occur in 4 circumstances, like simple hypertension without sclerosis, and then hypertension with involutionary sclerosis, and then arterial sclerosis, and then malignant hypertension. Okay. Then we have acute hypertensive choroidopathy. Okay, there are different lesions, and then management. Okay. Sciences.